Hello and welcome to Everyday Oral Surgery. This is your host, Dr. Grant Stuckey. I am an oral and maxillofacial surgeon practicing in Denver, Colorado. The goal of this podcast is to connect, learn, and inspire. In this podcast, you'll be hearing from OMS surgeons all over the globe discussing ways to improve the practice of oral and maxillofacial surgery. Most information shared in this podcast will be based on personal experience and opinions, so please supplement what you learn here with approved research studies. Without further ado, please enjoy today's episode. All right, welcome to another episode today with Dr. Michael Miloro. He is an oral and maxillofacial surgeon practicing in Chicago, Illinois. He's the department chair of the UIC program. Dr. Miloro, thank you for joining us on the podcast today.
Always great to be with you, Grant. Yep, thank you.
Yeah, I appreciate it. So, in residency, we all have many opportunities to present things in front of others. And we thought it would be a good kind of podcast topic to talk about presenting and maybe what are some of the skills or tips and things we can do to make an efficient presentation. And you taught us well, and I know you have many thoughts on this one, but maybe you could kick us off on that topic. What are your thoughts on it?
Yeah, I thought it was really important to get residents involved in public speaking right off the bat. And I think in the past, that wasn't the norm. But as you mentioned, I thought it was important because you're going to take oral boards for one reason. So you need to be able to articulate what you want to say in a logical and coherent manner. Where, doctor means teacher in Latin. So you're talking to patients. You need to learn how to talk to patients. And I think we taught you how to do that really well. And I think, as Seinfeld's famous quote, I'm a big Seinfeld fan. You are too, probably. There's always something applicable from Seinfeld to whatever we're talking about. And he said that people's number one fear is public speaking. And the number two fear is death. So he says, so that means for the average person, if you're attending a funeral, you'd rather be in the casket than doing the eulogy. And
hilarious.
Everyone gets nervous when speaking. I remember one of my mentors, Larry Peterson. I just joined the Ohio State University, and he was lecturing to the residents. And I asked him, do you get nervous before lecturing? You've lectured nationally, internationally. And he said, absolutely. Every time there's that adrenaline rush that you get, no matter to whom you are speaking. And I think that adrenaline rush really helps you. It keeps you alert and focused. So we kind of want that. And even I get the same way. So if I'm lecturing to residents or students or faculty or surgeons, again, nationally, internationally, there's always that element of anxiety that we get. And I think if you harness it appropriately, it's good for you. It can help the lecture.
Yeah, that's a good point. When I was in elementary school, I decided to run for student body president. And I remember we made a speech. I gave it in front of my cousins and my grandma. And my grandma stopped me. She cut me off in the middle of the presentation speech. She said, this is a snooze fest. You need to look up, you need to smile, you need to talk loud. That was the first experience I had with my presentation skills. And I started wheels turning in my head. But what are your thoughts? Because I think there's more than just delivering information from slides. It's kind of a way you deliver it. What do you think about that?
Totally. If you remember anything from this podcast about public speaking, it's that preparation is key. And now, when I design my lectures, I put a lot of work into my lectures. And over the years, I went from the lectures that were the blue background and the yellow words, and the whole slide was filled with words, to almost no words on the slides, just clinical photos. Because over the years, I've developed that clinical database, which I did not have when starting out. So, of course, I knew the literature, I knew the book, what the textbook said, and I put that in the slide, but anyone can just open the textbook and get that information. So it's really adding the personal touch and your clinical experience that really I'm focused on now when I design my slides. So you need to, I always say, more than probably most people in that audience do about the topic about which you're speaking that day. So you need to know the material, do the research, be prepared for questions, and practice out loud, videotape yourself. and try to avoid the ums and the uhs. Nobody in the audience likes to hear that. So, and that takes some experience to be able to carry on the conversation and avoid those interruptions. It can be really annoying to hear the ums and the uhs. So, the other thing is know your audience. You got to know to whom you're speaking. That lecture is about them. It's not about you. So you need to adjust it as needed. And again, I have a lecture on, whatever, mandible fractures that I'm giving to a student versus a resident versus a surgeon. It's going to be a very different lecture. So just the topic it has to change based upon the audience. Talking about the audience, the other thing about the audience is, to avoid stage fright, you used to imagine the audience in their underwear. was a popular way of doing it. So it makes them less intimidating for you and makes it easier for you to settle in to your talk. I think what I find myself doing is all of a sudden I engage eyes with somebody in the audience, and it's like I'm speaking to that person. And you don't want to spend too much time on that one person. You could shift it around. But again, if you're nervous with an audience of 200 people, you can try to focus on one person and then shift it to another person. So some other ways of getting over that stage fright when you're in front of a large group of people and you're not used to that large an audience.
I like that. Yeah, we've all been to lectures that are, incredible research content. The way it's delivered is very hard to digest, just because it's very, monotone. It's like you're saying, slides full of words, and your mind starts drifting, and you're like, what's going on here? And we've been to other lectures where maybe it wasn't that complex of a point, but the speaker was so passionate and dynamic that you couldn't help but listen. Like, you're transfixed.
Totally.
What are the what are the points there that help you to get to that point to be an engaging speaker like that?
Yeah, you said all the buzzwords there. You need to be passionate about the subject, and I lecture a lot on nerve injuries, and what I'm told after the lecture is, I can't believe how passionate you were about that. So now I know it really well. I think I probably know it better than anybody in the audience, and I have a lot of experience, so I'm very confident in it. But I'm also very passionate about helping those patients' quality of life, and that comes through in my lecture. So you have to show passion about the topic. You can't put yourself to sleep. You're going to put the audience to sleep for sure. So you got to engage the audience again as best you can. What is the average human attention span? Do you know? Most recently,
a minute or two. I don't know.
8 seconds.
Gosh.
8 seconds. So you need to grab their interest and engage them within the first, I'd say, 15 to 20 seconds. You get up there, and they put me to sleep before they even start talking about the topic. I'm Michael Miloro. I'm from Chicago, and I plan to talk about, how to diagnose and manage nerve injuries today. Well, the audience knows why they're there. You need to tell them that again. Start out by saying this, good morning. You can introduce yourself, but what you're going to get from this lecture is X, Y, Z. And I really like to put it in sort of a rule of threes, and that came from Steve Jobs, who said, keep it in threes. So 3 main points. Again, the other thing is, before I get to that, the lectures now have gone from an hour or 2 hours to 15 or 20 minutes. And that's great because, again, the attention span is really short. So you got to get that information out quickly. And you don't have to talk about the history of orthognathic surgery from the 1950s to present. You get to the point and you make the point. By the way, that's a much more difficult lecture to give. So you need to, if you're on a time crunch, to present an abstract at a meeting for 7 minutes or something, you need to really practice that and get that timing down. While if you're giving a lecture for an hour, you can go off on all these tangents that that the audience is not interested in. So I really like the short lectures in that 15 or 20 minute range. So the rule of threes, 3 main points that the audience is going to take away. That's all they can really digest. 3 examples of each point that you're going to make, maybe. Use things like 3-word phrases like life, liberty, and the pursuit of happiness, something like that. Those are easy things to remember. And it's more likely to improve memorability and it's easier to follow for the audience. So using rule of threes, but also, maybe trying, and I try to do this if I can, tell a story and start out, beginning, middle, and end of the story, and bring that end, wrap that end right around to the beginning again, and close the loop, close the circle. And I don't think we see a lot of that in lectures. Sometimes it's difficult to give a lecture like that. Maybe you can use a patient example and follow that patient through their injury, their diagnosis, the treatment options, and how you manage the patient, and how it turned out, something like that. So I think using the three takeaway points, and typically my last slide now is typically, this is what you should have taken away from this lecture, three main points. Because if you just end after you've been rambling for 15 or 20 minutes, they're not sure what's important. So you need to let them know what you think is important and what they could easily take home and use in their lives or in their practices. I remember the worst lecture I ever heard was, I could not believe it. It was 1 hour lecture on gunshot wounds in the maxillofacial region. And this speaker, who was a well-known speaker at the time, this is probably 20 years ago, read every single word, just from a piece of paper. And you really can't do that. You have to sort of find a balance between what you've prepared to speak about and ad-libbing. So I think that balance is sometimes hard to find. But again, practice makes perfect, hopefully. So practice, practice, practice. And you'll be prepared at the lecture.
I love the point of telling a story. So much more engaging to hear information through a story, through even a patient story, than through lists of data and facts and spreadsheets. I think too, another one is the element of humor and bringing some element. This is kind of a tough one because surgical professional things we're doing are very serious. I think a lot of us are very hesitant to be humorous, certain about telling stories, maybe HIPAA violations. But I don't know. What are your thoughts on that?
Yeah, in this day and age, you have to be really sensitive to the audience and sensitive to offending somebody with that joke. It better be like a dad joke that that most people would laugh at, because I avoid it. To be honest, I just avoid that. You don't want to be caught, and everyone's videotaping your lecture, and all of a sudden that shows up on social media that you said something inappropriate, or you thought it was just funny, but it turns out to be offensive to somebody or other. So I avoid that. But what you should do is let your personality come through. Every one of us is different, and we're a different person. We're a different speaker. Some of us are jovial when we speak. Some are very serious when we speak. So you should let your own personality come through as well.
Well, what I'm hearing from you is the importance of practicing, being able to semi-ad-lib and not having to read everything, presenting it in kind of a simplified manner with 2 or 3 main points. What tips do you have on the actual slides and the presentation that you're showing people, assuming you're doing a PowerPoint?
Yeah, like I said, I work really hard on those now, and I try to minimize the amount of words on the slide. Again, but if I'm teaching dental students, there's going to be many more words on the slide than if I'm lecturing to a group of experienced surgeons. So I think that rule of 6. The 6 lines on the slide, and less than 6 lines and less than 6 words per line. That's always been an effective strategy. But I think typically I'm much less than six lines and 6 words per line on my lectures now. But that's the rough guideline in designing your slides. And use fun templates. That blue one. I still see surgeons with that first PowerPoint template that ever came out, the blue one with the yellow words on it, and they still use that I think there are some slashes going through the middle of the slide, and I'm like, wow, that's an old one. There are some really good ones online. Using animations are really good also to emphasize your points, and a lot of online resources available to really beef up that PowerPoint. Using videos are really, really important. I think that I always had a problem with teaching dental students or residents how to take out a tooth, for example, in a textbook with a photo of it. So you see a photo of the forceps, and then you see the forceps on the tooth, and then you see the tooth out. And well, how did you get to that point? And that's where the videos really are critical. And I think when I'm lecturing and I'm showing a nerve repair video, I look at the audience and I think they're really engaged by watching that rather than just being bored staring at a slide of a nerve repair that's been done or the injury itself. So I think supplementing with videos is really important, and that it's so difficult to do well. As you may know, I've been searching for a good way to do surgical videos in the OR for many years. Some surgeons have a mounted camera to the headlight, to the overhead light, which you want. You want it to be static. Some mount it to their headlight, and their head's always moving, and that's not really effective. But you almost need a professional videographer to do that for you effectively. And what I find myself doing is spending hours and hours editing that video. So that video clip that I'm going to show to the audience is 10 or 15 seconds, 20 seconds, and it's taken me 5 hours to edit all of the video that I've taken in the OR. So it can be really time consuming. I spend hours on a lecture, and I think most of us do. It really is a lot of preparation. Again, I think for that lecture, you should organize that lecture. That's where preparation is key again. Just don't start typing the words onto a slide. Really just use a piece of paper first and say, here's my global view of how I see this lecture going, and use that as your template for then I'm going to use this case here and this case there. And again, that's where clinical experience comes in, is I've got a bank of patients, orthognathic class 2, class 3, whatever we have, and I need to plug one in there, and I can go to my database to do that and use the clinical case rather than a word slide to get my point across.
Nice. Okay. I feel like with the slides sometimes that people prepare these huge wordy slides because they kind of think about, these are going to be printed out, they're going to be given to attendees, they can study from these. And I almost feel like there needs to be like two sets, like a slide that's simple, maybe one sentence slide with a picture or a video. Because I feel like when you pop up, boom, you got a whole slide that's full of words. The audience immediately starts reading those words. They're not listening to anything you're saying. Unless you want to read the slide for them and then talk. Like, why do we have all these words we're reading and we're trying to listen to you at the same time? But, it creates an awkward experience for a listener. What do you think about that?
Totally. It's the wrong way to do it. It's the way I used to do it, though. We all used to do it that way. We'd read the slide, and the audience would read along with us, or they had read it already, and now they're bored because they just have to sit there and listen to us. And again, so I think the least amount of words on the slide, the better. So that's where in your PowerPoint, in your notes section, and hopefully you can use presenter view. So I think the main reason that most speakers who are not very experienced have so many words on their slides are they don't want to forget what the points that they want to make. So right. It's there so they don't forget to make those points. But you can take all of that, cut it, and paste it in your notes and use presenter view when you're presenting. So all of that information is there for you to see, and you just state those points bullet by bullet to the audience while they're looking at nice photographs of cases or whatever you're speaking about.
I like that a lot. Any tips for the brand new resident who's out of dental school and is, extremely afraid of presenting in front of all these knowledgeable surgeons and getting ripped to shreds afterward on all the stuff they said wrong? What are your thoughts on that one?
Yeah, it's tough. I mean, my favorite story, I don't know if I told you this one. I just became a senior resident at Penn, and I got an abstract accepted to the annual meeting. And at that time, the abstract sessions were extremely well attended. You couldn't even get in the room. They were so packed. And now it's sort of changed a little bit. There's less interest in the research and more in the plenary sessions. I'll never forget it. So I had practiced this. It was 7 minutes. I practiced it 100 times, and I had it down to the second to be able to finish on time. And it was a time of slide carousels. And I had to take the carousels on the plane with me in a slide carousel holder to make sure that they weren't lost. And I had back-to-back slide carousels. So there were two screens, and one would be on one screen, one would be on the other. It was pretty much on the left side screen would be the words, and on the right side screen would be the pictures. So the speaker before me presenting their abstract was just getting done. and I handed my carousels to the AV guy in the back. And as I'm walking up, he's loading them. And I get up to the podium. I forget who was moderating the session, but they said, okay, so this clicker, here's two clickers. This makes it go forward. This makes it go back. Here's a laser pointer. You have some, and it just started, and my head was spinning. And I look out into the audience, and in the front row, I'll never forget it, was Dr. Ellis and Dr. Wolford. And I'm staring at them, and I'm so nervous. And I have two clickers in my hands and a laser pointer. I'm like, I need a third hand because I'm not sure how I'm going to do this. And the first thing I did was I introduced myself and my topic, and I hit the wrong button on the slide carousel advancer. I hit the back button, and it jammed the slides and oh my gosh, and they wouldn't go forward, and I was stuck. So I look in the back, and can I get some help? And the AV guy removes both slide carousels, turns them over, the slides fall out of the carousel, and I'm just standing up there while he puts them back in, and he finally gets them in, and I'm like, it's like 4 or 5 minutes past already, and they took mercy on me and allowed me to finish, but it was like the worst possible case scenario. But there's no way to get around seeing, surgeons like that in the audience and thinking that they know more about that topic than you do. And most likely they don't. They probably know something about it, but you've done the research, you've done the in-depth work to prepare this lecture. And that would be my advice to you is, look, you've spent time on this, you know it probably as well as any resident or student is going to know it. So be confident in what you know and be prepared for the fact that you don't know everything, and they may ask you some questions, and it's okay to say, I don't know the answer to that. As you know, when I taught you, I don't know is a reasonable answer if you actually don't know. So that stage fright in front of experienced people that you've read their textbooks and you've read their articles is somewhat challenging.
I was appreciative that we had many opportunities to present in residency. We had case conference, grand round, implant conference. Multiple opportunities. And at some point, I don't know, during my first year, at some point along the way, I just decided that I was going to actively pursue these opportunities and try to present as much as possible, because I felt like my learning skyrocketed when I was preparing for these things. And then afterward, people would ask me questions and I wouldn't know, and I'd feel kind of awkward. I'd go home and research that up, and I'd never forget it. But any thoughts on that, like advice to a resident on things like that?
Yeah, well, when a question comes up in conference, as you know, the residents want that information immediately. They always have wanted me to just give them the answer. And I did my own internal experiment, and I gave them the answer. And 3 weeks later in conference, that same question came up. And of course, they didn't know the answer because they didn't do the work to learn the information. Now they just get on their phones and Google it, and they have the information right away. But again, I don't think that that's as effective as doing your own research and learning it. That really embeds it in your memory rather than just having that answer given to you. So you have to do the work. And we just had a new resident cohort start earlier this month, and that's the advice that we give them. We have grand rounds every week, and we give them a standard lecture, and we tell them that's only the beginning. It's a jump start for you to then do the work to learn this information. We're just organizing it for you based upon the OMSITE exam and the ABOMS written exam and what information we think that you should be learning and getting out of residency. But you have to do the work. So this 1 hour lecture is not everything that you need to know about mandible fractures. You need to then do your own research and reading.
I like that. Going back to that point about telling the story, there's so many books now coming out about how powerful a story is in a presentation. And I'll say too, at a young age in our church, they have us get up there and talk and give talks. We're like starting at 4 or 5 years old. But I think a lot of those who attend our type of church are more comfortable maybe doing that. But getting that exposure, feeling comfortable stories. One of the more dynamic speakers. Sorry to jump around here, but I was just thinking about Dr. Marks. And I know there's all sorts of controversy surrounding about what he actually is saying, but he's a hard guy not to listen to because he's so passionate. He'll get up there and tell the podium, tell these stories, and he's so dogmatic. And you're like, gosh, I've never heard anyone care that much about Like so exciting.
Right. Yeah. You want to avoid being so dogmatic about things and speaking with such conviction. You need to also understand that there are differences of opinion about things. Again, if I know the material really well and I'm an authority, like regarding nerve injuries, for example, I can speak with authority and conviction and be dogmatic. But if I'm talking about orthognathic surgery, for example, there are a lot of different ways to do it, and I have to be open to that and not lock myself into this is the only way to do it. Never say never, and never say always. So you have to be open to differences of opinion.
But still finding that balance of letting some passion and enthusiasm come through.
Yeah. I would say the other thing about lectures, when I lecture now nationally, internationally, what I want to do in preparation. So we talked about preparation of the lecture, getting the lecture ready. But what about preparation at the venue? I think it's really important. I like to get there early. I like to see the space. I like to walk the space, and I sometimes it's helpful to do some light exercise that morning, for example. If you're not going to exercise and go work out in the gym, go for a jog or stretch out, at least stretch or do something like that. Even just shake your arms, shake your body, get things loose a little bit. Remember to always breathe when you speak. So you have to have that, find that pace of deep breathing as you're speaking, so you don't seem like you're exhausted at the end of a sentence. So keep that breath going. I always try to start with some tongue twisters before I get up. So even before they start introducing me, just something, red leather, yellow leather, red leather, yellow leather, she sells seashells by the seashore, something like that. Just get your mouth moving and your tongue moving. And another key is always have some water up there, because you never know, you're going to get a cough. Something's going to get caught in your throat after speaking for 20 minutes or however long you're speaking. I've actually spoken, recently at a state society meeting for something like 8 hours. So by the time you're done, with a full day of speaking, you're going to need something for your voice. So maybe water, maybe Gatorade, maybe something, with some flavor in it is a little bit better. But that's part of the preparation, is to just not going up there without having, done the things I just talked about. Arrive early, survey the space, shake it out a little bit, exercise, breathe deeply, tongue twisters. I always do a tongue twister, just because if it's first lecture in the morning at 7 a.m., you're still waking up. You haven't spoken to anyone yet. You don't want your first words to be, part of your lecture.
Yeah, for sure. That reminds me of a presentation I gave, my very first residency, and I was tripping over the phrase inferior alveolar nerve, and I just couldn't get it out right. Everyone was looking at me like I'm an absolute idiot. But yeah, kind of practicing it, saying things out loud, and working through those words.
Yeah, those 3 words would be important for an oral surgeon to speak properly. Inferior alveolar nerve. Yeah.
Probably too, if you have video in your presentation, making sure that the IT guy can make it work, and it's all, you go through all that ahead of time.
For sure. Yeah. No, I've had that problem. It's typically I was one of the early Mac adopters. I used a Macintosh forever. And then as universities and speaking engagements went more to PC, it's difficult to use a Mac. Using Keynote, there might be some conversion problems that occur. And more now, they allow you to connect your laptop directly. If you have to give your presentation, and this recently happened to me, a PowerPoint created on a PC, given to them on a USB key, and once it got loaded, all the fonts were different, the templates were different. I just didn't understand what was happening. They might have imported it into something else, but the slides looked terrible. So if at all possible, if they're going to make you give it to them on a USB key, look at it before you get up there. But ideally, especially for the videos, you'd rather have your own laptop up there with you, that you've done the lecture, you've done the lectures, and you've practiced it on laptop.
Any advice on the Q&A portion, if there is that part presentation?
Yeah, it's a good point. There's always somebody who has a question to ask, no matter, they want to hear themselves speak, so they want to be seen in that lecture. and they want to have spoken with you. So if you're a famous speaker, they want to at least have a brief conversation with you. But I never ask a question that I don't think is going to benefit the entire audience. So frequently I have people come up to me after a nerve lecture presenting a case to me. I have this patient, I have a nerve injury, what do you think I should do? And that's fine. And that should not be asked during the main session. That should be a one-on-one later, but I get many of those. I think that a Q&A session is good if you've got multiple speakers. I really like that, to get differing opinions on that. And I was recently at a meeting where we had 3 speakers who got up there and answered the same questions in a different manner, and that's always a learning experience. So that's good. If you're the only speaker, I prefer that the questions wait to the end. It depends on the venue. So a small venue, I'll allow questions during the talk, but it interrupts my flow. So if you've prepared the lecture, you've practiced it, you've got a flow going, and that really throws a wrench into it. And the other reason not to have questions during the lecture is you may answer that question later on during your lecture. And frequently it happens all the time. So I'm asking a question, I'm like, I must have planted you in the audience because here's my next slide that answers that question. So sometimes they want to, they just want to show that they're paying attention, and they want to know what the next step in what you're going to talk about is, and it's right on the next slide. So I guess if I'm the only speaker, and the audience is more than just a group of residents where we're interacting and we can have that back and forth Q&A as the lecture's happening, I'd rather have the questions at the end of the lecture.
Any thoughts on doing things in the middle of the lecture or even pre-lecture to engage the audience more? I mean, I know there's sometimes we'll ask questions, we'll have different clickers and things like that. Sometimes in your residency, you can send out some info or questions ahead of time. So if you're thinking about this for my presentation coming up, I don't know, any thoughts around that type of thing?
Yeah, they're great. Now, if you're giving a lecture, for example, if you have a webinar for AMOS, you have to submit pre-lecture questions. So 3 pre-questions and 3 post-questions. And I think that's really useful to see where the knowledge gap is at the beginning and then see if it's filled at the end. The audience engagement with clickers is excellent if they're set up to do that. And some specific venues do ask you to do that during your lecture. I think it's such an effective way of teaching, but most are not like that. So if I throw a slide up in the middle of my talk with a question, A, B, C, D, and I ask the audience, I'm not sure that's that effective. I'm going to hear B, C, and I don't think that's very helpful. Maybe just to put the question out there as a question and then show them my process of how I got to my opinion and how I got to the answer for that question. I think that's effective. I probably should do some more of that because I think assessing the audience's knowledge and where the gaps are is really important, and we don't do enough of that.
Yeah, that seems like a great tool that can be utilized. All right, any advice, I guess, for the dental students who maybe aren't quite in residency yet, who want to prepare, want to harness those skills and get things going a little sooner than residency?
Yeah, depends on what they want to. If you're talking about an oral surgery resident or perio or ortho, whatever, what they could do is approach, and we've had this happen, just approach the program director of the program which they're thinking about. It doesn't, or another one, and say, hey, I've done this research project. Would you allow me to do a 5-minute talk on this during your departmental meeting? And I think that's very effective. So as you know, I don't know if you remember, when we had externs with us, and when we do have externs with us, we ask them to present. Every one of them, I want to hear them when they get up there and talk about, most of the time it's talking about research. Some of them have not done research, so they'll pick a topic to talk about. Again, I keep bringing up mandible fractures or something like that. Just give us a 5-minute talk on diagnosis and management of mandible fractures, or something that you feel comfortable talking about, extractions or implants or whatever. So just to put them up in front of us, and you could see a big difference between those who have given a speech before in front of people and those this is their first time ever speaking. So I think the earlier you speak, the better it will be, and early and often as much as you can. So and practicing it, video record yourself And I think that could be really helpful when you're starting out to try to hone your skills. I think it rarely gets to the point where you need medications for your stage fright, but sometimes it does. Sometimes a beta blocker can be really effective to help. And don't be afraid to use it as long as you've got no medical contraindications to use it. But that's another thing we didn't talk too much about, but it can be effective.
Yeah, I actually remember my co-resident told me he used some propranolol before his lectures to help calm things down for him. I also think, like you're saying, practicing and having somebody who's semi-knowledgeable go through the slides, hear you, like Scott and I, my co-resident, would do that. Like, hey, man, would you mind reviewing these slides and hearing me give this presentation? He gets some great feedback, but it's nice to have somebody who's knowledgeable.
100%. And when our residents present at a national conference, for example, an AMOS abstract, we will have them give us that PowerPoint and we will hone it down for them. So I'll do what I suggested before. I'll take all the words off their main slide and put it in their notes so that it's off that, and try to redesign their slides. It's so funny that if you look at my slides now, I will maximize the photo, that surgical photo, as big as possible. And the residents, or I see other surgeons, the picture is really small. As the words are huge and the picture is small. And all we really care about in the audience is seeing the details in that surgical photo. So my other advice is maximize the size of those surgical photos, and almost never say never, but almost never have a slide with just words on it. And that's my advice to young speakers is you might have words on it, but always have a picture next to it. Always give the audience something to engage them, to look at, that's visually appealing, rather than just staring at those words that, as you said before, either they're going to read before you or they're going to read along with you, which is not an effective way of teaching or giving a talk.
That's excellent. Yeah, really good advice. I appreciate you sharing. Any other pro tips on presenting?
I think there are a lot of online resources available to help beyond what we've talked about today. I think things like using hand gestures appropriately, taking pauses, especially pauses between those 3 points. Don't forget the threes. Threes are really important. So between those 3 points that you want to make in that lecture, take a pause, maybe move to a different part of the stage. And that's another thing is where are you physically located? Do you have a stationary mic? Or do you have a lavalier that you can walk around? And some people are more comfortable with one versus the other. But you have to be able to adapt, because some venues want you to use the lavalier and walk around, and others have you just fixed at the podium with the microphone. Now, if you're walking around with a lavalier mic, you do not have access to your presenter view or your notes. So you have to take that into consideration too. That's a much more difficult lecture to give. You need to know your information cold, exactly what you're going to talk about and what's coming next, because you can't see that on the slide presenter view. So that's if you're gonna walk around, you need to know your material. And like I said, I think I could do both. I like both. I think standing in one spot is, as I've gotten older and more experienced, is less desirable for me. I'd rather be walking around and mobile, because standing in one spot, especially for an hour or more, if you're giving that long of a talk, it starts to wear on you. And you're fixed to that microphone. So I'd rather have one that I can walk around with. I think it's more engaging for the audience to watch you. And again, like I just said, is taking pauses between the points that you're trying to make is an effective teaching strategy as well.
Then one last question. Any tips on if you are showing patient photos, patient info? I mean, what's the rule there on out things or blurring things?
Yeah, that's a very sensitive issue, and you'll see many speakers at the beginning, they'll say, please no photography, and on every single slide, they have a picture of a camera with a big circle and an X through the camera saying, do not take a picture. So they're using space on every slide, where a picture could be bigger. They have a picture of a camera that's blocked out saying, please no photographs. And despite that, the audience is taking photographs. And these are patients. Hopefully, I have it easy at the university. I have it easy because when a patient registers, they sign on their registration form something that says that I can use their photographs or videos for educational purposes. And I think most universities have that disclaimer. In private practice, you may have that. If you don't have that and you plan to lecture as a private practitioner, you might want to put that in your consent, your overall registration consent for the patient, because it would be an ethical HIPAA and HIPAA related issue if they saw themselves in online, for example. I can't tell you that I see my own slides online now. I see my own patients in a slide deck from a different country of my own patients. So I remember I was lecturing in Turkey once, and a guy in the front row had a fixed camera on a tripod, just taking, every time I changed the slide, I heard the click of his camera. And I called the organizers over. I said, he's taking pictures of every single one of my slides. I said, if he wants it, I'm happy to give him the words, off my slides, but the patients, that's another issue. And I don't know if he's trying to make his own slides, his own PowerPoint presentation, based upon my experience. There's an app, Microsoft Lens, Lens, that if you're in a lecture and you hold up, it's a camera, it's in the app as a camera. And if you're on the side of the lecture hall and the slide is kind of, either trapezoidal or rhomboidal, or just not the right shape, not rectangular, and you take that photo, this app will correct that to make it a perfect slide for you. So you could be anywhere in the room, and have the wrong aspect ratio on that photo, but it will correct it for you. So essentially, you could be at a lecture and you can create the entire PowerPoint using this app. And I think it really offends some surgeons when you do that. Not me. I think it's happening. So I don't say do not take pictures of my slides, because I don't think that's going to be effective. And I think it sets it up as a hostile environment. So I don't know if you've been to a lecture where the surgeon, it says that right up front. It's almost before he or she introduces themselves, say no photographs, and they're really dogmatic about it. And then, like I said, every slide has a camera, with a circle with an X on it saying no photographs. I don't like doing that. You could say it once, but that's it. I don't say it at all, because I think it's going to happen. And I think it brings up another point about social media and posting, before and afters of patients. Again, you need to, do it in a professional way, a respectful way. And sometimes, even if I have their permission on their registration consent, if I'm posting something on social media of a patient, I will ask them specifically by email, is it okay if I do this? And most of them will say yes. I said I'm using it as a teaching, as an educational tool, not so much as a marketing tool. So you have to really, decide on what your goal of social media is. Is it marketing your practice, or is it, to educate other surgeons, young surgeons? And for me, pretty much it's education and not so much marketing.
Got it. Well, I love these points. I really like your point about simplifying things to 3 main points. Sometimes at AMIS, I know like they're always trying to get new topics. Sometimes I feel like the topics, the speakers are being so technical. It's almost like they're speaking to a colleague that's specialized in their field. I feel like this is a room of 300 or 400 people, like probably maybe 2 or 3 are following some of the things they're saying. I just wish there was more of us make basic points, and it's fine to technical stuff, but it would be nice to get a little more, what are the main distilled power tips here? Really, really nuanced things about maybe craniosynostosis, how to treat these things where you're looking around and everyone's kind of, sure we're following this.
Right. Nice pictures that we're seeing here, but it's not my area of expertise. I think an effective strategy is also showing complications. We learn so much from complications, and those lectures are always packed. So disasters from the masters, if you've heard of that from AMIS and other venues are using that, those rooms are packed because we want to hear from somebody and not just see their best case. Also, we want to see their worst case. And some lectures are called My Worst Case Ever, and how you managed it. So we all have complications, and learning from them is really very valuable. So yeah, I mean, you if you're not interested in craniofacial surgery, you probably wouldn't be at that lecture anyway. So right. And it's tough to make that generalizable for everyone at every level in that audience. So that's why we have at AMIS, we've designed the lectures to be opposing lectures that we think that people would not have an interest in, like pitting pitting TMJ against dental implants or something like that. So if you're interested in one of those, you can attend one of those. And if you're not interested in the other, you don't need to attend it, but you can always watch it later. And that's where making the videos available after is important also, because none of us have time during a busy meeting to see everything we want to see. So the recordings can be really effective as well.
Yeah, that's actually been huge for me, because I go through those after the meeting and I'll search for ones and find ones I missed, and I love watching those videos and slowing things down and rewinding it and going through it.
For sure. Yeah.
Excellent. Well, Sherry, thank you so much for sharing content and your thoughts on presenting. I think it's, as we know, the way we learn in our profession is transmitted from surgeon to surgeon. The way we teach each other is critical, and it's not always in the OR, somebody pointing things out. Sometimes it's a slide, it's a presentation. There's all sorts of ways we learn things. So I feel like the more we can harness those skills and teach more effectively, it's benefits all of us.
Yeah, for sure. And it's like surgery. I mean, if you don't use it, you lose it. It's like, you have to continue to practice, and the more you practice, the better you'll get, as with anything. So with public speaking and giving lectures, you need to just continue to do it and work through those flaws of the ums and the uhs and the awkward pauses, and become an effective speaker. It takes years. That's the thing to remember, is it doesn't happen immediately. It takes years to develop and hone those skills. So be patient.
That's a good point. All right. Well, if you're okay with it, I can put your contact info in the show notes in case listeners have further questions. I'll put mine as well. But yeah, I really appreciate you taking the time and running through.
Sure, my pleasure. Always.
Thank you so much. Real quick, I have to ask if you read any good books in the last year or two that you would recommend to us.
I'm reading A Massacre in Mexico. I went to Mexico. I've been to Mexico many times on cleft mission trips, and one time I'm into skulls as a craniomaxillofacial surgeon, and I found, and it's right in my office here. It's on the wall. You can't see it. It's a print of Ayotzinapa of 43 skulls. So I didn't know what it meant when I saw it in the store, and I bought it from this print shop. But it's 43 skulls, and it's meant to represent the students in Ayotzinapa, Mexico, that were going to protest some government regulation, and they magically disappeared one day. And this was on national news 10, 12 years ago, and I come to realize that I didn't know what the story was, and I found out there's a book called Massacre in Mexico. So it goes through an account of, as best they know, what happened to these students, and ultimately, I think it was the government had them killed because they were protesting some government regulations. So I'm working through this book right now that's pretty powerful, and again, no answers were ever found as to what happened to these 43 students that disappeared, but that's what I'm reading now.
Well, I love that you're always learning, always looking for new information and things to sharpen your mind. Thank you, Dr. Miloro. I appreciate you.
So you're not going to ask me what forceps I use to extract a tooth? I'm Michael Miloro. I do not take out teeth anymore.
That's what I figured. I should skip the thing. I figured you'd be like, I don't do any of that stuff anymore.
I'm kidding. Yes.
Any good movies that you've seen recently?
Let's see. I think the answer is no. I'm more of a miniseries kind of person. Squid Game. I was hooked with Squid Game and watched the third season. Still hooked. Hooked on White Lotus. My wife and I enjoy that, so we've seen the third season of that. Looking forward to the fourth season. If I need to get in front of the television at all, I'm gonna probably watch some reruns of either Seinfeld or, more likely these days, Sopranos. So I can never get enough Sopranos, and I learn something new every time I watch that. And it's just such great acting and directing there that I can never get enough Sopranos.
Love that. Do you ever go to the AMC or the movies?
It's been a while. Yeah, I can't remember the last movie I saw on the big screen. Yeah, it's been a while. Would you recommend anything?
I mean, I thought F1 was really good with Brad Pitt. It was a great movie. Good message. Yeah, there's some good ones out.
Yeah.
Superman. You brought up Seinfeld. Do you remember that scene where Jerry and George are in Monk's Cafe? Jerry says to George, like, what kind of lives are these for a living? We're not men.
Yeah, man, absolutely. Absolutely. Yep. Yep. Dr. Markowitz and I talk about that. We bring up that line quite often. Yeah. Yeah. We speak in Seinfeldese all day long. I mean, it's like we speak a different language when you're talking Seinfeld, and you really need to know it, but it is like in the daily vernacular to use Seinfeld quotes.
Oh, that's so great. I actually went to a stand-up here in Denver a few months ago. Like, he was so dynamic and hilarious and so relatable, all the stuff he's saying. I'm pretty sure he's the only billionaire that has actually done stand-up and is still doing it. I mean, it's remarkable. So clearly he's got a passion for it. So,
yeah, for sure. For sure. Yep.
All right. Well, thank you for your time. I appreciate you.
Pleasure, Grant. All right. Take care. Thanks.
Thank you so much for listening to this episode of Everyday Oral Surgery. For more information on these podcasts, please visit everydayOralSurgery.com. I love feedback and would be very grateful if you would reach out to me via my email, grantstuckey@gmail.com, and let me know what you thought of this episode. Or you can text me at 720-441-6059. Additionally, if you have any topics you'd like to hear about, or if you would like to be a guest on the podcast, please email or text me. I found many of my interviewees through people who have been contacting me and have been listening, and I've gotten so many great ideas for more podcasts, and that's what helps keep the podcast rolling. So I really appreciate you making that extra effort and helping me out with feedback and knowing what to do next on the podcast. Thank you so much.